बिस्मिल्लाहिर्रहमानिर्रहीम। अस्सलाम वालेकुम। मेरा नाम डॉक्टर नवीद है। मैं आखान यूनिवर्सिटी हॉस्पिटल में पीडियाट्रिक इंटेंसिविस्ट के तौर पे काम कर रहा हूँ। एंड इन द नेक्स्ट फ्यू मिनट्स, in the next 30 to 35 minutes, I will be discussing about nutritional support in critically ill children. So I have no disclosure for this presentation. The objectives of this presentation will going to include why the nutrition is important in the critically ill patients, especially in the ICU, how the nutritional status is assessed, how much calories are enough for critically ill children, when and how to start and escalate the enteral feedings, few myths about the enteral feedings, and just briefly touch about the total parenteral nutrition in the ICU. So why it is really important? Because malnutrition, including obesity, is associated with adverse clinical outcome, including long period of ventilation, high risk of hospital acquired infections, longer PICU and hospital length of stay, and increased morbidity. And this is a well-known fact. And this is a study in which they have looked into the database of patients in which they have included 90 PICUs, can included now almost more than 1,600 patients from 16 countries. And it does shows that almost half of the population were malnourished in terms of underweight, overweight, and obese. And it does see it was increased. There was increased association of underweight with the mortality, with the infections as well. And another study does shows the impact of malnutrition in critically ill children. It does shows that patients who were malnourished survived less as compared to those who were normally nourished during the ICU stay. So it is significantly associated with mortality. Another study it does shows that in those patients who in which malnutrition was absent, their survival rate was pretty high as compared to those patients who have non-specific malnutrition, or those who, especially those which is common in our society, that in our population in resource-limited setting, that children do present with protein energy malnutrition, and they have a significant higher mortality in among these patients. So if we're going to look into what metabolic changes occur in the ICU, whenever there is a critical illness, and whether it is due to the trauma, patients are being admitted due to trauma, patients are being admitted due to any other illness, sepsis, burn, surgery, they undergo a phase of catabolism, that is they undergo fatty lipolysis, that is fatty acid oxidation, glycolysis occur, there is decreased utilization of these, and there is a muscle breakdown. It does lead to loss of lean body mass, and it does lead to increased glucose, that is hyperglycemia, which in turn in the liver in turns these protein amino acids are being converted into acute inflammatory proteins, which causes tissue repair and wound healing, as well as gluconeogenesis, which results in further increase in the glucose and urea, resulting in the fuel for brain as well as RBCs and kidneys to provide more energies. So this mainly occurs in the whenever the patient is being admitted into the PICU and they are in the catabolic phase. So the main aim is to prevent that catabolic phase. And there is this is a very important concept with regard to simple versus stressful starvation. In the simple starvation, you can see that which we usually occur in the month of Ramadan, that is pretty normal, and it has a very good effects on the body. But when it occurs in a stressful situation, the basal metabolic rate is increased almost twice. Oxygen consumption is significantly increased. Protein catabolism is significantly increased. Weight loss is pretty rapid, and lean body mass loss is pretty early. And there is a protein catabolism. If it continues, there is insulin, cortisol, and catecholamines increase, leading to further gluconeogenesis and increased ketones and increase in gluconeogenesis. So remember, when the patient is being admitted in ICU, they are in a stressful state, and when we're going to starve them, that will going to have a deleterious effect on their metabolism and their supply of and their nutritional needs. So how the nutrition is being assessed. Nutritional status assessment in critically ill children involves weight, which is pretty common in our situation. Usually weight 50th percentile for that age is being taken into account. Macronutrients for the fat, one you can usually take the tricep skin fold thickness, as well as for somatic protein, mid-arm circumference. For visceral protein, serum albumin can be done, as well as for the macronutrients, individual assays like vitamin assays, as well as macronutrient assays, and for the immune state, total lymphocyte count and skin energy tests can be done. And these are the deficiency states and cutoff values for these, and it should be done for every children upon admission, and then it should be repeated at least weekly during an ICU stay or during the hospitalization, so that the nutritional status can be assessed accordingly, and intervention can be done accordingly in these patients. For the how much calories does this patient usually require? This is for the direct calorimetry, it is not always possible, but however, it is possible to do the indirect calorimetry. It is common in the West, and it can be done by attaching the patient to the monitors, which can assess the how much oxygen is being consumed and how much CO2 is being exhaled, and that will going to give the respiratory quotient, and through that one can identify how much calories are being required, as it is seen in this graph, that one can assess how much need or 24-hour caloric need of the patient would be, how much energy expenditure is, and one can after 24 hours of attaching the patient to this machine, and some ventilators nowadays does have this indirect calorimetry as well, so you can attach those patients to those ventilators like GE ventilator, so one can assess their energy requirement in the next 24 hours, and one can then give the nutrition accordingly. For the WHO calculation, usually if the patient is being admitted to ICU, 1.3 stress factor with the basal metabolic rate is being added, and one can multiply it to get the how much calories is being required. So this is the predicted energy expenditure of the healthy children. For the infant, it is around 100 kilocalories per kg per day. For 1 to 3 years, it is around 80 kilocalories per kg per day. For 4 to 5 years, 70 kilocalories per kg per day, and then so on from 6 to 8 years, it is 60 to 65 kilocalories per kg per day, and from 9 years onward, it is around 35 to 45 kilocalories per kg per day as that of the adults. And then if we were going to consider the basal metabolic rate, that is how much calories is being required for the basal metabolic rate for the infants and younger children, it is around 50% for the school going age, it is around 40 to 45 to 50%, and then if we were going to consider in the adolescent, it is around 40 to 45%. It is almost similar. There are discrepancy, some slight difference in the male and female. If you are going to consider, almost 40 to 50% is the basal metabolic rate for the pediatric population overall. And what are the metabolic responses in critical illnesses that can lead to increased energy expenditure? There are different conditions that lead to increased energy expenditure and metabolic demand, which require extra amount of energy to be provided in terms of nutrition, and that includes burns, that is an extreme hypermetabolism in early stages with protein requirement which can be double, in sepsis, that is upregulated fat oxidation and increased energy requirements, congenital heart diseases that increases the energy expenditure, fluid restriction, and may absorb nutrients very poorly, so there is increased energy requirement in those, and after cardiac surgery there is a risk of underfeeding because of the fluid restriction, therefore they need to be looked into, as well as after abdominal surgeries, especially in newborns who have undergone abdominal surgeries, there is an increased resting energy expenditure at 4 hours, followed by the return to baseline in 12 to 24 hours. Surgery in general, it can cause hyperglycemia response, and that is negatively correlated with the age, and 12 hours in neonates and 24 to 48 hours in children. children, and that can be balanced as well. And on mechanical ventilation, resting energy expenditure can be reduced due to inactivity and absence of growth, and decrease in sensible fluid losses. So in that case, one can decrease the amount of nutrition provided to these patients, especially if these patients are being kept sedated and their basal and their activity is being restricted. So one can cut down their basal metabolic, cut down their energy intake to 60 to 70 kilocalories per kg per day. What are these different stress factors? And if you're going to look into different stress factors like mild starvation, one need to add 0.85 to 1 stress factor, post-operative state 1 to 1.05. In cancers, patients are on the hypermetabolic state, then it has to be around 1.1 to 1.45. In peritonitis and in sepsis, it is 1.05 to 1.25, and in multiple trauma and burns, it is pretty high, and they usually require significant amount of calories, and especially in the initial phase, and that is around 1.2 to 1.55 factor is being added to their basal metabolic rate. So other than that, other factors that can increase the caloric intake, that can increase the requirement for energy are the adrenaline infusion, noradrenaline infusion, dopamine infusion, dopamine infusion. At the same time, if the patients are being on sedatives, and that decreases the energy expenditure, beta blockers, morphine, and if the patient is on ventilator, that decreases the energy expenditure less than 25%. So these are the factors that needs to be taken care of, and that needs to be kept in mind while taking care of children while they are in the ICU. How much minimal calories and protein intake? At least 2/3 of the required calories and a minimum of 1.5 grams per kg per day of protein intake should reach on third or second day for the critical illness, and less than this much of protein results in negative balance, and that can result in loss of muscle mass, as we have seen in the previous slide. That can lead to protein breakdown and decrease in the lean body mass of the children. When enteral nutrition should be started, and it should be started as early as possible, although the recent guidelines does show that it should be started as early as possible within 24 to 48 hours. But now the new protocol is, one of the quality indicators in most of the ICUs is if the feeding is being started within 4 hours of the ICU admission. If there are no contraindication or absolute contraindication, one need to start the feeding within 4 hours of the ICU admission. So how to initiate and how the advancement of the feeds needs to be done. There are different algorithms that are being utilized, and different hospitals have developed their own algorithms. Different countries have adopted it according to their need, and it can vary, but one commonly used is according to age, that is feed requirement, and whether you need to advance them in a standard way or in a conservative way if the patient is in shock, or if the patient have some abdominal pathology, or the patient does have abdominal infection. One can go for the conservative approach. In that, you need to double the timings of the feeding. For example, if in the infant you have started 15 ml per kg every 3 hourly, then you can increase, starting volume is 3 ml per kg, and then you can increase it 3 ml per kg every 3 hourly. But if you want it to be more conservative, you can continue the same amount of increasing, that is 3 ml per kg, but you can increase it every 6 hourly. So you can double that part, or you can cut the amount of feed in which you are giving to have if you want it to be more conservative. Usually it is seen that if we have a standardized protocol for feed advancement and for feed initiation, that's really important, and that will going to bring about a significant change in the caloric intake, and through that you can achieve the amount of calories which you are required to achieve in 2 to 3 days. You will be able to achieve it. But if you don't have a protocolized management, and you will not be able to achieve, and individually people can increase it pretty slowly, and the children can go into those stressful situations, and in the catabolic phase, in which they usually decrease their lean body mass and they go into catabolism. So we need to prevent that. And for the continuous advancement in the same way, one can use the standardized approach to reach the goal in 12 to 18 hours. However, if you wanted to continue it as a conservative approach, you need to achieve the goal in 24 to 36 hours, slowly and gradually, with half the amount which is being recommended in the standard approach. So according to age, you can increase it and accordingly, and that's how you can do it. And the focus should be that the protocolized management should be taken into account while feeding these children. Sorry. So if we were going to look into the intensive care feeding algorithm, if the patient is being admitted into the ICU and is being considered for the enteral nutrition, then one can start the enteral nutrition within 48 hours and can be able to achieve the goal within 72 hours of treatment. If you are not being able to achieve the goal, then you need to either consider prokinetic or post-pyloric tube, or if you are being able to achieve it, then you can reach the 100% of the nutritional requirement in the next 24-48 hours. And however, if you're not being able to start the enteral feeding, then you need to consider parenteral nutrition, but not very early. We're going to discuss it in the other discussion when we're going to go into parenteral nutrition about the trial which was being done. Conditions that exclude need for enteral nutrition include if the patient is taking orally well, will receive oral intake within 24 hours and receive palliation, receiving palliative care. And conditions that warrant starting parenteral feeding include acute pancreatitis, and if it is pretty sick and with multi-organ dysfunction, enteric anastomosis, ischemic bowel, enteric fistula, imminent bowel resection, imminent endoscopy, bowel obstruction, high nasogastric losses on admission, and severe exacerbation of inflammatory bowel disease. So these are some conditions in which a patient can be considered to start on parenteral nutrition. What are the myths about enteral nutrition? And I will going to stay on this slide for some time to discuss about the common myths which are being there. So starvation or undernutrition is okay, as we have discussed in previously that starvation in the normal healthy individual is okay, but in a patient who is stressed, who is in a stress, as all the patients who are being admitted in the ICU, they are in a stressful situation. So starvation is pretty bad for them, and it can lead to further devastating condition among these patients. Parenteral nutrition is safe. It's not safe. It has its own deleterious effects, and we're going to discuss, and we're going to see it in the next few slides. So if the parenteral nutrition needs to be started, it needs to be started not early, but if the patient has absolute contraindication, then one can consider starting them early as well. Enteral nutrition contraindicated with the vasopressors. As if the patient is on vasopressors and pretty high vasopressors, then definitely one cannot start the feeding right away, but at least start them on trophic feed so that they cannot develop submucosal atrophy. So it's a common myth not to start with the vasopressors, but you can even if the patient is on inotropic support and they are stable, they are not on fluid resuscitation, you can start them on enteral feeding, not in a full flat but in a conservative way, and then look into it whether they are tolerating it. If they are tolerating it, you can increase it in a conservative way. The fourth myth, which is early enteral nutrition is not important in patient receiving mechanical ventilation. That is not true. As I have mentioned that nowadays it is as early as we can start the enteral nutrition that will going to have beneficial effect on the patient, and so most of the hospitals have made it as a quality indicator that if the patient is being admitted to the PICU and they need to be started within 4 hours of ICU admission, enteral feeding, and that is their quality indicator, and one need to look into if there are no contraindication and if there are no issues to start with the enteral nutrition. The fifth one is enteral nutrition is contraindicated with high residual. So nowadays, gastric residual volume are not being checked until unless there are issues of obstruction, until unless there are issues of gut issues. Otherwise, no gastric residuals are being checked, and enteral nutrition is being given right away. If there are gastric residual coming, however, it is not recommended to check them. However, if they are being checked, it needs to be reversed back, and enteral nutrition needs to be continued, not to be discontinued. It is one of the commonest factor in which people are not being able to achieve the targeted enteral nutrition, and people usually tend to see the aspirate every 3 hourly or 4 hourly aspirate, where if there are few aspirates, and they usually halt the feeding. That is not the that should not be done, and would encourage not to look into the residuals and continue with the feeding, and to achieve the target feed as quickly as possible in a standardized way, as we have discussed in the earlier slide. For the post-pyloric feeding, reduces the risk of aspiration. It has been seen nowadays as well that in a patient who are being fed with a post-pyloric feed, they do have some element of gastroesophageal reflux, and they can aspirate as well. So it is not true that post-pyloric feeding reduces the risk of aspiration. You need to take other measures of aspiration, that is keeping the patient upright at 30 degrees and making sure they are on prokinetics as well. Then the seventh myth is mainly related to it is contraindication with without bowel sounds or post-operative alias. So post-operative alias, if the gut is not functioning, definitely people do hear the bowel sounds, but nowadays they do look into ultrasound as well, and they do look into they don't usually move forward with the bowel. If there are no bowel sounds, it doesn't mean that the gut is not moving or the gut is not working. So this is another common myth, and that the people usually don't start the feeding, that they don't hear the bowel sounds. So we need to look into other perspective as well. If the patient is fine, the child is passing stool, and if the child is passing gases as well, and however, even if there is no bowel sound, you need to start them on feeding, at least with the start with a conservative way, and then if they tolerate it, you can increase them in a conservative way. Enteral feeding is contraindicated following GI surgery. Nowadays, early enteral nutrition has been recommended. That is even after the anastomosis, surgeons used to start them on early feeding so that they should not undergo submucosal atrophy, which can lead to further GI incoordination, and which can further lead to increase risk of feeding intolerance, and one can prevent that by starting them on early feeding in a conservative way. Enteral feeding is contraindicated in patients with open abdomen. That is also another myth. Patients are exposed to liver transplants, patients who have open abdomen with a mesh over it, they can be started on feeding, and they can be fed through the NG, or they can be fed orally until their abdomen is sometimes abdomen is closed in a serial manner. So they have to undergo multiple surgeries for that, but they don't need to be kept NPO for the whole period of open abdomen. If the gut is fine, one can continue to start feeding as well. For the enteral nutrition is contraindicated in patients with pancreatitis, so it is not contraindicated nowadays, and people are there are trials, and it does shows that if the nutrition is being started early in these patients, usually now the surgeons usually start them on feeding in a conservative way on second day as well, on second day of admission as well. If there are no complications, they usually continue to progress it in a conservative way. Patients must be fed in semi-recumbent position at 45 degrees. That is not true as well. Patient can be fed at 30 degrees, and it is recommended, especially in those patients who have GERD, you need to keep them upright, but not all patients needs to be kept upright for the feeding. They can be kept they can be fed while they are lying down as well. So these are the common myths and you can visit them in the below mentioned citation. So what are the barriers to optimal nutrition, enteral nutrition, and what are the suggested management? It includes interruption of the enteral nutrition, and the most common reason, as I have mentioned, feeding intolerance, any procedures, or enteral access issues, if there are, then these are the common. And what are the suggested approaches? And apply uniform definition, as I have mentioned, and that don't look into the gastric residuals, review the fasting guidelines for the procedures, and resume the feeding if there is a delay in the procedure or if it is cancelled, and request for a specialized team for enteral access, like radiological incorporation, to put the GJ tube, NJ tube, so that the feeding would be started. For the fluid restriction, patient with cardiac or renal conditions, consider a concentrated formula, get help with the dietitian, and review other fluids as well. If the patient is on vasoactive concerns, there is vasoactive drugs like vasopressors. There is a concern for gut ischemia, but it is prudent to hold the enteral nutrition when actively resuscitating with the fluids and hemodynamic are worsening, or there are multiple vasoactive support. However, if consider enteral nutrition, starting enteral nutrition in a conservative way, if there is no fluid resuscitation over 12 hours, or a single or stable vasoactive support is being there, and monitor closely while advancing the feed in a conservative way. If there is a delay in enteral nutrition initiation, that is failure to prioritize, educate, develop institutional specific and uniform guidelines for the nutrition delivery. As I have mentioned, the protocols are being developed, and one of the quality indicators people used to use in the ICU to start the feeding within 4 hours of ICU admission, that should prevent delay in enteral nutrition initiation. And then general reluctance to address nutritional delivery, that is failure to prioritize the nutrition support. Then create nutritional support teams within your not only the doctors but also nurses, dietitian, and they work collaboratively. You request dietitian dedicated to the ICU so that they can look into each and every patient, involve key stakeholders, and develop multi-professional consensus on nutritional therapy goals in your institution. So there are other considering the immunonutrition, there is no proven benefit, hence not routinely recommended to add immunonutrition. For the macronutrients, it is individualized according to the testing. If it is on the lower side, definitely, or if the patient is definitely deficient in the macronutrient, it needs to be replenished and prescribed accordingly. Coming on to the parenteral nutrition, why do we initiate parenteral nutrition? It should be considered within a week in malnourished, and after 1 week in a normal nutritional status according to the established guidelines. There are multi-center studies. There is one multi-center trial for early versus late parenteral nutrition, and it shows there is no difference in the mortality among the two groups, and there is a high risk of infection if the parenteral nutrition is being started early, and there is early discharge, low ventilator days in patients who have late parenteral nutrition. So it has been recommended, therefore, that to think about parenteral nutrition. If the patient is not tolerating enteral feeding, then you can think of starting it late toward a week or more than that. For the parenteral nutritional indication barrier, if the patient, you are not being able to give the enteral nutrition, like there is a known or presumed gut ischemia, if there is a persistent hemodynamic instability, if there is a gut graft versus host disease, there is a malabsorptive state, that is a short gut syndrome, if there is an intra-abdominal hypertension and there is compromise of the gut supply, blood supply, then and there is intractable emesis or planned NPO for more than 72 hours, then one can consider using it. For the nutritional requirement in the parenteral nutrition, it is water intake 30 to 50 ml per kg per day, calories 25 to 35 kilocalories per kg per day, with 60% of fat and 60% of carbohydrate and 40% of fat, and protein intake 1.2 to 1.5 grams per kg per day, and then it can be further increased further. For the sodium, 1 milliequivalent per kg per day, potassium 2 milliequivalent, addition of magnesium, calcium, phosphorus, trace elements and vitamins as needed. So it's just a generalized concept now how to write a TPN prescription. We're not going to go into detail, but there is a detailed form which is usually available within the pharmacies, and they usually and within the hospitals, that needs to be taken care of in terms of how much amino acid requirement has been there, how much, what was the lab values, different lab values of the patient. Accordingly, that has to be managed with how much electrolytes needs to be added, how much vitamin B complex or other medications needs to be added in the TPN, and how much fluid requirement is there and how much fluid needs to be restricted. That all depends on how much TPN needs to be given. And general consideration for the good practice of TPN, daily requirement of calories, daily requirement of other energies, different electrolytes and other things are being given, and these are being added into the TPN. So one most important thing is the role of dedicated dietary team. ICU care is all about multidisciplinary teamwork, where the physician, nurses, respiratory therapists, dietitian, pharmacists, etc. all are involved in the patient care. And a study done at AKU compared pre-nutritional support team with post-nutritional support team intervention and found significant difference in the starting and establishment of the caloric goals after the nursing team has been added into the ICU rounds. So it is a well-known phenomena that we need to have a dedicated dietitian to the ICU teams so that they can take care of the children and work collaboratively with the ICU team to overcome the catabolic phase in which the children are usually in the ICUs, and to provide them adequate calories so that they cannot go into catabolic phase, and that is stressful response. So in summary, the take-home message, dietary status assessment should be an integral part of PICU management. Enteral feeding should be initiated and escalated early if not contraindicated. As I have mentioned, it is now a quality indicator to start the feeding within 4 hours of ICU admission. We need to consider that if possible. And the ICU physician should be aware of the TPN prescription and monitoring, and dedicated dietary team is the need of the day in the ICU. Thank you. Thank you very much now for your time.